my privilege to moderate this afternoon's session on religion, spirituality, and end-of-life outcomes. Before I introduce our first presenter, I'll just say a little bit about the format. We'll have a presentation by Dr. Tracy Balboni and then Dr. Michael Balboni, followed by a panel discussion and audience participation, more than we've been able to have in the last hour. And then I'll be sure to finish us up by 3:45 in time for the reception. Our discussants will be Dr. Daniel Solmesi and Dr. Christina Pachowski, and I'll introduce them a little later. Dr. Tracy Balboni is an associate professor at Harvard Medical School, where she co-directs the Harvard Initiative on Health, Religion, and Spirituality. She's a radiation oncologist at the Brigham and Dana-Farber, board certified in palliative care. She serves as the clinical director of the Supportive and Palliative Care Palliative Radiation Oncology Service, which serves patients facing life-threatening cancer. Her primary research interests are in spirituality and palliative care and radiotherapy for palliation. Tracy?
Okay, thank you, John. Can everyone hear me okay? Great. Well, it's been a wonderful day with you so far, and it's really just terrific to hear the conversation regarding all of these issues. Thank you to all of you for coming. Thank you to our presenters once again for all of the effort in being here among us. As you may have noticed, what we're doing is we're going from two extremes, from health to now the end of life. And by doing this, by sort of framing the life experience, we're aiming to begin to have a conversation of how this might begin to fill our whole understanding of health from health and wellness to the very end of life. So in that vein, we're moving to research that helps us to understand the role of religion and spirituality in end-of-life outcomes. So I'm going to be doing three things today. First, I'm going to be providing you with a bit of background, the background that sort of undergirds some of our more recent research efforts. And that background really describes what we know about the role of religion, spirituality in the experience of a serious illness. I'll then take you through what our next steps have been, how we've, based on this backdrop, developed research questions, and then begun to test these hypotheses. And then finally, I'll spend a brief minute just talking about some of the challenges. And we've already touched on this today, this issue of moving from, it's sort of our medical term, or especially oncology term, of moving from the bench or the lab to the bedside. And there are many challenges in that have already been pointing out today, and certainly in the care of patients facing serious illness. So starting with our background, as you know, religion, spirituality is important to the majority of patients, and it in fact has the highest endorsements among certain racial and ethnic minority groups in the US, for example, among African Americans and Latinos. We know in the setting of illness, it's very important to coping as well as to quality of life. We also have from our background information that it impacts medical decision-making, particularly some religious variables. And finally, we also see that the provision of spiritual care to patients, when we have a medical team, including chaplains, doctors, nurses, social workers, et cetera, that's addressing their care, and religious communities as well that are addressing and providing spiritual care to patients, it impacts patient medical decision-making as well as quality of life. So I'm going to drill down into this background a little bit further just to show you some examples of research that form that background. One is this study performed by Andrea Enzinger, now Andrea Phelps, through the Coping with Cancer study. The Coping with Cancer study is a multi-site cohort study. The PI is Holly Prigerson, now at Cornell, which was performed at multiple sites in the United States on patients who had advanced cancers and an estimated life expectancy of 6 months or less. And they followed patients prospectively, so they interviewed them at baseline and then followed them until the end of life. And they actually followed their caregivers, their family caregivers as well in regard to their bereavement outcomes. And at baseline, what was assessed is via Pargament's religious coping scale, their degree of positive religious coping. And you can see in this bar graph here, high religious coping at baseline is shown in the dark blue, and low religious coping is shown in the light blue. This was just via a median split. On our y-axis or on our x-axis here, we have the types of aggressive medical interventions that patients were receiving at the end of life. So on your left, ventilation, then resuscitation, any intensive life-prolonging care, such as being admitted to an intensive care unit, being resuscitated, and then finally dying in the ICU. And what this study shows is that patients who reported, highly relying upon their religious beliefs to cope with their illness at baseline were receiving greater aggressive medical interventions at the end of life. So really suggesting that patients' religious coping is in fact somehow interfacing with the way that they're going about making medical decisions. This and other data have provided support for guidelines regarding providing spiritual care to patients, as we have also discussed today, particularly at the end of life. Although medical team spiritual support is unfortunately often infrequent, we wanted to look at, through the Coping with Cancer study, how, when it is present, how it impacts patients and their quality of life at the end of life. This was also through the Coping with Cancer study. Measured at baseline were two separate measures of how patients were being supported by their medical team, spiritually supported, and as well as sort of a more concrete measure, whether or not they were receiving chaplaincy visits. And what I'm showing you here is on the y-axis, patient's quality of life near the end of life. It was actually measured by a caregiver who was present in the last week of life. Increasing numbers correlate to or correspond to better patient quality of life at the end of life. So here on our x-axis are the spiritual support measures, again, performed at baseline. And you can see that when patients reported spiritual support from the medical team, they had better quality of life at the end of life. When they were receiving pastoral care services, again, better quality of life at the end of life. And then finally, when they were receiving any form of spiritual care versus no spiritual care, those are the patients that had the best quality of life at the end of life. So suggesting that medical team spiritual support is really important to patient well-being. Something that I think all of us would understand to likely be true, but actually providing the empirical evidence to support it. These are actually adjusted findings, adjusted for things like patient demographic, disease factors, as well as, importantly, patient's quality of life at baseline. But what about how does the provision of spiritual support impact medical decision-making? We saw a moment ago that high religious coping patients are receiving greater aggressive care at the end of life. What about when various spiritual supporters, whether medical teams or religious communities, when they are interfacing with patients, how does that go on to impact patients' receipt of various forms of end-of-life care? So these are the analyses, again, from Coping with Cancer 1, looking at the report of spiritual support from two different sources, from the medical team and from religious communities, and looking at its relationship to hospice care. And you can see here in adjusted analyses, when patients reported high spiritual support from the medical team, they had a threefold greater odds of transitioning to receiving hospice care at the end of life. When they reported high spiritual support from religious communities, however, the result was in fact the opposite, about a 2.5-fold decrease odds of receiving hospice care at the end of life. We see sort of what you would expect to be the pattern for aggressive measures at the end of life. Again, things like being ventilated, being resuscitated, that when patients report high spiritual support from the medical team, they have much lower odds of receiving any aggressive interventions, whereas when they're reporting high spiritual support from religious communities, they have a much higher rate of going on to receive those interventions in the last week of life. Just to explore a bit further within these patients receiving high spiritual support from religious communities, how this plays out in different portions of the patient sample. So this is just the raw data, the receipt of aggressive medical interventions in the full sample. These aren't adjusted analyses. I'm just showing you the differences between those receiving high spiritual support in the dark blue and low spiritual support in the light blue. you can see there's a small difference here, but when you go to patients who are reporting high religious coping, remember those high religious coping patients are the ones who are more apt to receive greater aggressive interventions at the end of life. Those are the patients that have the greatest effect of high spiritual support from religious communities going on to further increase their risk of receiving aggressive interventions at the end of life. And a very similar finding for racial and ethnic minorities, which in this sample, US sample, was predominantly African American and Latino patients. And a very similar finding for ultimately dying in an intensive care unit. So based on these data, we had many, of course, I'm sure you already have in the room many questions as to, why some of these findings? Why is high religious coping related to greater aggressive care at the end of life? Why is it that when religious communities are supporting patients that we're seeing more aggressive interventions at the end of life? And why, when medical teams are providing that same form of care, why it must be somehow different? They're receiving less aggressive interventions at the end of life, and they also have better quality of life at the end of life. Interestingly, religious community spiritual support was not related to greater or to better quality of life at the end of life. It was only medical team spiritual support that had that relationship. So this sort of led us to pose a number of research questions and to go on to begin to test those hypotheses. And so one question, there can be many, but these are some of the questions that were raised by the data, is, given that we know the role of religion and spirituality in illness, we have national care quality guidelines which call us to provide spiritual care. A critical key question in light of those factors and a critical to spiritual care provision is, what are the religious and spiritual beliefs and values that are influencing this process of end-of-life medical decision-making, whether for a religious patient or for a religious community providing spiritual care for that patient. And another question that's raised is, given the salient role of religion and spirituality for many racial and ethnic minorities, particularly in the US, and data already showing that these are patients who, though they often have disparities in care the opposite direction before the end of life, getting less care than they should receive, actually end up with greater aggressive medical interventions at the end of life. Another question is, how do these religious beliefs and values influence what we know to be racial and ethnic disparities in end-of-life medical decision-making and care? I do want to point out, one question that often comes up is, well, aggressive medical interventions, which can be a religiously consistent way of dying, and at times need to be upheld as that, but we do have evidence to suggest that it does have deleterious consequences. So, for example, those patients consistently have much poorer quality of life, measures of their quality of life at the end of life. Their caregivers have worse bereavement outcomes, much higher rates of depression and PTSD. So there's reason to suggest that, though yes, there may be times when that form of approach to the end of life, death in an intensive care unit, et cetera, at times is an appropriate death for patients. Many times it's actually harmful to patients and to families. So we can begin by thinking of a model of how we might begin to understand the relationship between patient, religion, spirituality, their religious and spiritual supporters, and their end-of-life outcomes. This is a fairly simplistic model, but it helps to guide how we might pose research questions. But we can imagine that we have patients' religion, their spirituality. It's made up of their various values, their beliefs, as well as functioning through coping. Also, as we've discussed earlier, perhaps creating a number of needs, spiritual concerns, spiritual struggles, et cetera. And all of these things might be then going on to impact end-of-life medical decision-making and ultimately patients' quality of life. We can see that when, for spiritual care from religious communities, perhaps when religious communities are providing spiritual care to patients, perhaps their emphasis is more on things like values and beliefs that are associated with greater aggressive end-of-life care, less transitioning to hospice, and greater aggressive interventions. So, for example, the belief in a miracle might be one example. One wonders, especially since we didn't see a relationship with quality of life at the end of life, is maybe is there more of an emphasis here on beliefs and values at the end of life? And perhaps does there need to be more focus on coping, on spiritual needs, and perhaps that is not present? In contrast, if we think about spiritual care from the medical team and the relationships that we saw there, perhaps in this setting, particularly because we have the benefit of chaplains, et cetera, those individuals, perhaps more aware of the medical realities of illness, also aware of the many coping and spiritual needs issues that can arise in the setting of illness, are focusing a bit more on these issues, leading to better patient quality of life, and perhaps somehow interfacing with patients' values and their beliefs in a way that helps them to steer away from aggressive interventions at the end of life. So that sort of model undergirds these research hypotheses that patients' religious and spiritual beliefs and values regarding end-of-life care are frequently present, and that they're influencing medical care received at the end of life. And also that these beliefs and values, when they are more prominent, so for example in certain racial and ethnic minority groups, contribute to racial and ethnic differences in end-of-life care. So we pose these questions within the Holly Priggerson's Coping with Cancer 2 study. This is another very similarly designed study to Coping with Cancer 1, except that it was specifically examining the role of patient-provider communication in end-of-life disparities, in racial and ethnic disparities in end-of-life medical care. And some of the outcomes that were examined include things like end-of-life treatment preferences among patients, their illness understanding, and their quality of life. So in this study, 7 questions based on what has been present in the literature assessed religious beliefs about end-of-life medical care that might be related to greater aggressive interventions at the end of life. These were posed to patients, and then they were asked to indicate their degree of agreement on a 5-point response option from not at all to a great deal. Quite a bit and a great deal were considered to be endorsement of that belief. And then patients' end-of-life treatment preferences here were assessed with a fairly standard item, the support item, where patients indicated whether they would prefer a course of treatment that focused on extending life as much as possible, even if it meant more pain and discomfort, or a plan of care that focused on relieving pain and discomfort as much as possible, even if it meant not living as long. So these are the religious beliefs about end-of-life care, medical care items that were developed. I'll just read them to you. I think it's important to hear them. So first, my belief in God relieves me of needing to think about future medical decisions, for example, a DNR order or a healthcare proxy, especially near the end of life. I will accept every possible medical treatment because my faith tells me to do everything I can to stay alive longer. I think agreeing to a do not resuscitate order is immoral because of my religious beliefs. I would be giving up on my faith if I stopped pursuing cancer treatment. I believe that God could perform a miracle in curing me of cancer. I must faithfully endure painful medical procedures because suffering is part of God's way of testing me, and my faith helps me to endure the suffering that comes with difficult medical treatments. So these are data on those items, and I just want to first draw your attention to these are, again, the highest 2 categories of endorsement for each of those items. And one of the first things that struck me, because when we posed these items, I thought that there would be endorsement, but honestly, I didn't think it would be as frequent as what we're seeing here, is just how commonly these are endorsed. So for example, my belief in God relieving me of having to think about end-of-life medical decisions, 42% of the sample. I accept every possible medical treatment because my faith tells me to, 61%. And of course, miracles, perhaps not so surprising, 2/3 of patients, and faith helping me to endure suffering from medical treatments, over half of patients. And you can see when you look at whites, blacks, and Latinos, there are also differences between groups, and when you do an analysis comparing the 2, you can see that these religious beliefs about end-of-life care are actually more frequent among African American and Latino patients. So we created among these 7 religious beliefs about end-of-life care, we examined them to see if we could look at them as a whole. So we did a factor analysis, and there was, in fact, a single factor supporting or creating sort of an average score between all of the 7 items. We looked at how the RBEC score, what we call the RBEC score, just to make it not so much of a mouthful, related to race, ethnicity, and indeed race ethnicity was associated with higher religious beliefs about end-of-life care. We then looked at the relationship of these religious beliefs about end-of-life care, measured as the RBEC score, to its relationship to treatment preferences, together with race and ethnicity, and used a multivariate analysis to control for significant demographic as well as religious and spiritual confounding variables. So on univariate analysis, I'll just point out a few pieces that are interesting. So the RBEC score was associated with greater preference for aggressive end-of-life care. As well, Black race was also associated with greater preference for aggressive end-of-life care, but not the case among the Latino patients. But in multivariate analysis, where all these variables were put together, the RBEC score predicted greater preference for aggressive end-of-life care. That relationship remained, but race was now no longer a significant factor in predicting end-of-life treatment preferences. So just in summary, in regard to these findings, religious beliefs about end-of-life medical care are common, and significantly more so among certain minority groups, such as African Americans and Latino patients in the United States. These beliefs about around end-of-life medical care are related to greater preference for aggressive end-of-life medical care, and they in fact may also be one of the mediating factors in racial and ethnic differences that we see in the receipt of aggressive end-of-life care. So I just finally, with that sort of overview of the research, just want to point out a few of these bench-to-bedside challenges that we face. And many of them have been raised already today, but I just want to highlight them again. And first and foremost, that there are these ethical, theological, and professional issues that we have to sort of engage with in order to decide how we're going to be interfacing and providing spiritual care to patients, and how we even begin to engage things like patients' religious beliefs and values as they face end-of-life medical decision-making. And first and foremost, it's that, obviously religion, spirituality isn't a tool to manipulate for medical purposes. Such a use of religion and spirituality would defy the very heart of what religion and spirituality is. It's a good, it's a value in and of itself. And other issues include that, we know that, yes, as I said before, that approaching the end of life may at sometimes be the most religiously consistent by approaching the end of life with aggressive end of life care. But we also know at the same time that there are rich theologies of dying, embracing alternatives to aggressive end of life care. So how do we begin to engage that? How do we begin to engage religious communities in a way that allow those to infiltrate in to the medical setting? And how to do that is quite difficult, especially while trying to use religion and spirituality to manipulate it for medical purposes. We don't want to be inviting people in just for the purpose of trying to make sure that they're not ending up in ICUs and costing our healthcare system dollars. That's a utilitarian use of religion and spirituality that we, of course, want to avoid. Also, of course, is this issue of who has what roles in the medical setting between, chaplains and nurses and social workers and physicians and local religious leaders and congregants. How do we begin to provide this care in a way that especially overcomes frequently the silos that are present between these groups, as well as shortages of chaplains, for example. These are all sort of challenges we need to be considering, and yet we can't say to these challenges, well, are we going to be able to overcome them? We have to overcome them. We have to overcome them. We have national guidelines that show and indicate and will further support the provision of spiritual care to patients and their families at the end of life. So it's a question of not of whether or not we will go forward. We do need to go forward, but how will we go forward? And one of a key sort of next step clearly is to develop and test a model for spiritual care provision to seriously ill patients and families. But I put test in the little quotation because should we test it? Is it a good that we should uphold no matter what? Which is, again, one of these challenges in moving from the research setting to the actual provision and embracing of who patients are spiritually as well as physically, emotionally, and socially. So I do just want to take a moment to acknowledge I'm speaking about research that is the result of so many different organizations and persons' efforts. Certainly the research support from the Templeton Foundation and others, the many research collaborators, and of course, first and foremost, to the patients and the families that made this sort of research possible. Thank you very much.
Thank you, Tracy.